important. So treating fever is very difficult. And as I said at the outset, my knowledge is far from complete. But yes, in the heat, at Delhi, it was 44 degrees yesterday. I was very happy when I boarded the flight at 5 a.m. in the morning, 6 a.m. in the morning. But yes, I would. Kavitha Sarabu is one of the leading persons who probably is dealing with melioidosis and has a long series.
Another very small question, maybe silly one for you, that in Northeast states, even the patient comes with the AES with fever for even 1 or 2 days, they start doxycycline, presumably thinking that it's a case of scrub, and what because they are economically not that too much about your AIMS or your Lady Hardinge. So how do you assess this? How do you stamp this? Yes, they should do or not. What's your idea?
Lady Hardinge is not a very rich hospital. Dr. Ghosh, I would just like to say, I am also working. It is a government hospital, although it is a central government hospital. But I would, what Dr. Shibendu Ghosh wants to say, I would just say in other words, the cost of investigating a person for a disease which is undifferentiated is far higher than our ordinary antibiotics, which will be much more effective. So doxycycline, probably a course of doxycycline would not even cost 150 rupees. For a 7-day or 10-day course, it would not cost 150 rupees. And number one, the investigation cost would be in thousands. Number two, for scrub typhus, the laboratory tests that are available with us are not standardized. What we were relying upon was Wheel Felix test, for which the antigens, heterophile antigen antibody test that is there, that antigen is not standardized and available. Number two, the ideal test is immunofluorescence, which is again not available with us, and PCR again is not available. What we do is a indirect ELISA testing, which is done. So it is not universally available with everybody. So the cost of giving, because encephalitis worsening and having complications is far worse. So any patient, if you do not have undifferentiated, I mean differentiated or localizing sign, or what we call as a PDC, potential diagnostic clue, it is better to give empirically treatment, because patient is our foremost responsibility. Patient welfare. Yes, sir.
Dr. Anupam, thank you for your nice talk. I just agree with Dr. Tapos about the melioidosis. The melioidosis cases are increasing, especially in Tamil Nadu and Karnataka, and though not common in our part. And many labs are also lacking the facility for diagnosis. Though ultimately we need a blood culture to detect Burkholderia pseudomyeli. and it causes acute encephalitis-like syndrome, especially in children. So we must be careful, and we must keep in mind only with high degree of suspicion
Yes.
we can diagnose, because it is very, very less common in our part.
And our experience is limited.
Yes, as you have told that travel is very weak now, and Dr. Jayant Panda told me that yes, in Odisha also they got bilharziosis cases. It presents with fever and features of pneumonia mainly. Lung involvement is predominant, but it can affect any organ, and sometimes it can be fatal by causing septicemia and organ failure. So that is why I have actually raised the question of milioidosis. That is very important. You should not actually forget about milioidosis once you are not finding any reliable causes. So they have definite causes.
And
Now
in case of milioidosis, one important thing is that it causes multiple abscesses in different organs like liver, spleen, especially prostate. This is one clue for the diagnosis of milioidosis.
Sir, milioidosis is, it has a number of forms, clinical presentations.
Yes, yes.
One obviously is the commonest is the pneumonitic patch that is there. But if it goes into the septicemic phase,
Yes.
then it manifests into the florid form, and all organ involvement may be there. And at times it will result in abscess formation.
Yes.
Wherever you will have, then you can have brain abscess, liver abscess,
Yes.
all organ abscess may be there. And that is why if you do not suspect these diseases, at times we may land to trouble.
And when this abscess occurs in lung, it is confused with lung abscess even.
Dr. Ananda Bagchi, please stop. We are lagging
we are
behind our
overshooting
time.
the time.
So excellent deliberations by both of our doyens. One is Professor Jayant Panda. He is doyen in metabolic disorders with special reference to diabetes. Another doyen is in infective diseases. So we are really thankful to both of you to come over all the way from your state, that is Delhi and Odisha, over here to deliver this sort of very beautiful lectures. Thank you very much. Now, may I request both of you come over here. This is the time for felicitation.
I request the chairpersons to felicitate Dr. Jayant Panda and Dr. Anupam Prakash. Now I request Professor M.K. Rai and Professor S.B. Ganguly to please come up on stage. একটু দাঁড়ান স্যার, আমি দেখেছি ওদের। স্যারা দেখে। Professor M.K. Rai and Professor S.B. Ganguly to hand over the memento to the chairpersons.
Good afternoon to my young friends over here. So now we are moving on to the case-based discussion. And with that, I would like to invite upon the podium our learned chairpersons, Dr. H.S. Pathak. He is the retired professor and head of the Department of Medicine in JNM College and Hospital. and he's also the chairman of API West Bengal branch. Next, I would like to invite Dr. Shibendu Ghosh. He is the professor of GIMSH and the chairman of Scientific Committee, API West Bengal branch. Sir, please come onto the podium. Next, I would like to invite Dr. Partha Chatterjee, professor and head of the Department of College of Medicine and Sagar Datta Hospital. I think he is not here right now. He'll be joining us soon. Next, I would like to invite Dr. Shomik Datta. He's the professor of General Medicine, Bardhaman Medical College and Hospital. With that, I would like to give the mic on to our chairpersons to explain the rules and the regulations of the case-based discussion by our 4 postgraduate trainees. Thank you.
So welcome everyone to this learning platform. And right now we are scheduled for a very stimulating session, case-based discussion. Shelly, Debrup, Ritik and Shovik, they are waiting for this session with their cases fresh from words. And just to remind everyone that it's a competitive session, and I'll request Professor Pathak, my co-chair, to remind the rules of this session to the competitor. So, Professor Pathak, please.
It's a competitive session. Somebody will get the prize, but others may also get some consolation prizes. So you will have to stick. You will be evaluated by 5 parameters: time management, quality of slide presentation, your oral presentation, interaction with judges, and relevance of the topic. These are the 5 points under which you will be evaluated. So take care of all these points for getting good marks. So we will invite.
I think enough has been talked about. Now I request Dr. Shelly Jain to present his case. And it is strict time. Please stick to the time, 12:03. And floor is not in this the presentation. Floor is not usually allowed to involve themselves. Thank you very much.
Good afternoon, respected professors and my dear colleagues. My topic for today is Anasarca, a diagnostic conundrum. A 14-year-old male presented with a history of low-grade fever associated with rash for 5 months, followed by generalized swelling and scanty reddish micturition. Patient was experiencing low-grade fever for 5 months, which was initially continuous and later became intermittent on starting medication. Patient's mother noticed reddish-black raised spots on face, which later became generalized, involving the whole body within 15 days of fever. Rashes healed in around 2 weeks, leaving hyperpigmented spots without scarring. Patient also gave a history of excessive hair loss. Patient's mother first noticed facial puffiness, which was mainly periorbital 4.5 months back, which was acute in onset and gradually progressed to involve the lower limbs, abdomen, and later the whole body. Swelling was painless and pitting in nature. Urine output was reduced with reddish discoloration. During previous hospitalization in a local hospital, patient had 1 episode of GTCS, which was controlled by medication. Patient had no history which was suggestive of sore throat, chill, rigor, cough, hemoptysis, weight loss, diurnal variation, or night sweats. There was no itching of rash or any association with exposure to sunlight. No bleeding gums, epistaxis, or melena. There was no history of chest pain, dizziness, palpitation, or PND. There was no focal or generalized neurological weakness or involvement. Multiple joint pains or deformity was not given in history, Ulcer in oral cavity or nasal mucosa, no history suggestive of Raynaud's phenomenon. He did not suffer from sore throat 1 to 3 weeks before the onset of symptom. There was no history of jaundice or any viral infection. No history suggestive of drug hypersensitivity, type 1 diabetes, or hypertension. Family history did not have any hypertension, diabetes, or any other illness in parents. No history of any hearing deformity in father or his siblings. No family history of tuberculosis. Patient was hospitalized twice in a local hospital before presenting to us. He was mainly on diuretics, oral steroids, anti-epileptics, and acyclovir for a suspected herpes zoster. There was no history of any nephrotoxic drug intake. So we went further with clinical examination. On general examination, patient was alert, conscious, and cooperative. Decubitus was of choice. Built-in nutrition could not be assessed due to presence of anasarca. He had a pale and puffy face with periorbital edema and narrowing of palpebral fissure. There was mild pallor, but no cyanosis, icterus, or clubbing. He had generalized spitting edema, jugular vein was engorged, lymph nodes were not palpable, sternal tenderness was absent. He was tachypneic, and also respiratory rate was 26 per minute and tachycardia was there. Pulse was 120 per minute but regular. Bilaterally, respiration was bilaterally equal in movement. Temperature was 100°F and blood pressure was 130 by 90 millimeters of mercury. On examination, we found painless oral ulcer over hard parrot. Hyperpigmented macules over face was present, also involving scalp, trunk, upper and lower limb, both extensor and flexor surfaces. He had non-scarring alopecia on scalp with soft, fine, easily pluckable hair. He had Terry's nail and hemorrhagic atrial macules. So we went further with systemic examination. On genitourinary and gastrointestinal system examination, there was generalized swelling of abdomen with flanks full. Umbilicus was everted midline and had transverse slit. Parietal edema was present. Fluid thrill was present. There was no organomegaly. Renal angle was not tender. Shifting dullness was present. Respiratory system, breathing was thoraco-abdominal and regular in nature. Bilateral fullness of intercostal space was noted. There was no tracheal shift. Bilaterally, stony dullness was noted on percussion. And there was diminished vesicular breath sounds bilaterally. There was no adventitious sounds heard. There was no abnormality present on inspection of cardiovascular system, no visible pulsations. Apex beat was in a normal position. No murmurs audible on auscultation. Central nervous system, all cranial, motor, sensory, and autonomic functions were normal. To summarize, my patient had low-grade fever associated with hyperpigmented non-scarring rash and excessive hair loss for 5 months. He had generalized swelling and scanty reddish micturition for 4.5 months. And he had painless oral ulcer, non-scarring alopecia with bilateral pleural effusion and ascites. So what could be the possibilities? The first differential diagnosis that we thought of was nephrotic syndrome, systemic lupus erythematosus, infective endocarditis. So we went further with lab investigations. Complete hemogram showed anemia. The patient had anemia. Hemoglobin was 7.7. The total leukocyte count, neutrophil, lymphocyte were all within normal limit. Platelet was 313,000. ESR was 20 meters per our direct Coombs test was negative. We went further with routine urine examination. It was acidic in nature. Pus cell was 6 to 7 per high power field. Albumin was present. Occult blood was present. There was deposits. RBCs were 8 to 10 per high power field. Urine culture did not show any growth. 24-hour urine protein was high. It was 5 grams. On biochemical parameters, urea was 170 and creatinine was 1.5. Triglycerides were also raised. Total cholesterol was 270. HDL was 50. LFT showed reduced albumin, 2.6 grams per dl. Rest was within normal limits. Sodium, potassium, calcium were all normal. CRP was 1.4. Chest X-ray showed bilateral pleural effusion. Ultrasonography of abdomen showed bilaterally raised echogenicity of kidney. Ascites was present. Kidney size were a bit reduced to 9.59, right one, and the left one was 9.96. Rest were within normal limits. ECG was normal. Echocardiography did not show anything significant. MRI brain showed subacute chronic and chronic ischemic changes at right insular cortex, perisylvan region, left parieto-occipital region, and right posterior centrum semiovate. What could we further with specific investigations? ANA came to be positive. The titer was 1:160. The intensity was 4+, and it was coarse speckled. Serum C3 was reduced. Serum C4 was also significantly reduced to less than 6.95. dsDNA was positive. RNP and anti-Smith was positive, but APLA was negative. So we went on with renal biopsy. It showed membranous lupus nephritis. It was a mixed kind of a picture, class 3 and class 5. The activity index was 2 and chronicity index was 0. So we arrived at the final diagnosis. It was a case of childhood systemic lupus erythematosus in a male patient presenting with lupus nephritis and neurolupus. The management that we went forward with was we gave an induction of IV cyclophosphamide. We gave diuretics, anti-epileptics, antihypertensives, statins, 3 days of IV steroids followed by oral steroids, hydroxychloroquine. So why was I willing to present this case? It was a case of childhood SLE, which is a term used to describe SLE in age less than 18 years. Childhood SLE accounts for only 10 to 20% of all lupus patients. And the ratio between male and female, which is in adults, it's 9:1 for 9 for female, 1 for male. But in case of pediatric population, it is a bit less. It is 2 to 5:1. Studies suggest that childhood SLE has got a higher prevalence of renal involvement. And there is wide variation in literature of incidence of neuropsychiatric SLE in children compared to that of adult. But certain symptoms like epilepsy, psychosis, and cognitive impairment occur more commonly in children. Thank you.
I will have to paste one question each from each judge. Now, on what clinical grounds you suspected or included infective endocarditis as one of the possibilities?
So patient had a long-standing low-grade fever associated with rash, reddish, micturition, seizures, and so that is why mainly, and also anasarca. So we kept it as one of the possibilities, but
What was the age of the patient?
so it was 14 years.
And what was the response? How was the response?
So response was good, seizures subsided, and so he's still on follow-up actually.
Okay.
He's getting cyclophosphamide. He got 2 doses yet, so he's on follow-up.
I've got two questions rather. One is clinical. You have shown in your this thing from 6th page onwards anteriorly you find dullness. Yes. Am I correct?
Yes.
So where from this dullness starts normal persons in the anterior part of the chest?
Sir,
Yes. Where from dullness starts in the anteriorly?
sir, actually, it will depend on the liver and the spleen.
So please read it out. It is not right what you are written.
Yes.
And think, where is the, if the patient has so many problems, why you are thinking only nephrotic syndrome in this patient? Why not say nephrotic syndrome? Second, your first diagnosis or only nephrotic? Why you think of only nephrotic?
So we
Patient
went
has
on
so many
with
problems
the
here.
commonest thing first and then to the rarer things. So the commonest thing in this age group was nephrotic syndrome. So we went further with nephrotic, but then we found out that it was much more than that. So we went further with ANA and more specific investigation.
Is renal biopsy was very necessary in this patient?
Yes, sir. So
Why?
because the protein, it depends on the protein loss and hematuria. So here we had RBCs in the urine, which was more than 3, and there was also protein loss, which was more than 500 mg per 24 hours. So the PCR was raised. That is why
You cannot treat the patient on the basis of
no, so
the
we can
blood.
treat the patient, but we can, but based on the lupus nephritis classification, if it was class 1 or 2, he would not need induction, or even for 5 and 6, but for 3 and 4, he will need induction. That is why we went
Your
for.
complements are reduced. You have got telltale evidence of DNA positive and all these things. I don't
in the emergency, particularly where you cannot do it, how will you do? Thank you very much.
Thank you, sir.
So I'm sorry, this is a request from our. No? So there is some change, there is some change. No, no, I'm not thinking. There is some change in our schedule. I'm sorry to say the request from our, more from academic body. This is a announcement that Dr. Devrata Rai and Dr. Arpita Raichuri, both of them are in a hurry. So I request Dr. Devrata Rai to start his deliberation, and the PGT will be again taken up after this meeting, these two lectures are given. Sorry for the inconvenience for both the audience or the PGTs and all.
May I request Professor Atul Chandra Saha, who had been professor at IPGMR Medical College, and Dr.
Good afternoon, everybody. We will move on to our next session. Our next session is on cardiology updates. To chair the session, I would like to invite Dr. Professor Sorojit Bunik and Dr. Professor Atul Chandra Saha. I will like to request the chairpersons to kindly introduce the speaker.
The previous speaker, initial diagnosis told first is your nephrotic syndrome, okay, and secondly she uttered that the second diagnosis is SLE. This cannot be the provisional diagnosis. The diagnosis should be in a syndromatic approach. No, please let me finish. I wanted to tell you, please allow me. As we are a teacher, so I think the approach should have been So good afternoon, everybody. Now we are starting this session of on cardiology, and the speaker is none other than the renowned interventional cardiologist in this part of the country, Dr. Devrata Rai, and we are eager to listen him. And sir, this is yours.
Thank you, Chairperson, sir, and very good afternoon to you all. I must extend my thanks to the scientific committee of West Bengal API for extending me this privilege to deliver a lecture on single antiplatelet therapy, that is SAPT, or double antiplatelet therapy, that is DAPT, what to use after PCI. Now, as you all know, DAPT has been a dictum after PCI. But with the advent of newer antiplatelet agents, especially the P2Y12 inhibitors, we started to think whether we can withdraw aspirin and whether this withdrawal will induce patient benefit or harm or no difference compared with continued medication. Now, what we are so eager for an aspirin-free strategy in PCI. Of course, there are problems with aspirin like gastrotoxicity, vasoconstriction at high dose, and not to forget about aspirin resistance. But what we are really concerned about is the bleeding risk that we face with aspirin. Both ACUITY and ADEPT-DSS showed that any major bleed post-discharge or within 30 days of discharge increased the risk of mortality significantly, and the bleeding risk is as important as ischemic risk for a patient undergoing PCI. Now, the burning question is, can we evolve a strategy that reduces bleeding risk without compromising the ischemic risk? So you see the early trials, the DAPT and the Pegasus TIMI 54, and where aspirin was used as antiplatelet monotherapy, and both of them showed a favorable response with DAPT as far as ischemic risk is concerned. However, there is an increased risk of bleeding. The scenario, however, changed with introduction of the newer generations of P2Y12 inhibitors, especially ticagrelor. And as you can see from the latest trials, like Global Leaders and STOP DAPT-2, where a monotherapy with ticagrelor or clopidogrel can reduce the ischemic events as well as the bleeding risk. And in some others, like Twilight ACS sub-study or the SMART choice, where it is non-inferior as far as ischemic risk is concerned, but is associated with a significant lower risk of bleeding. So to evolve a meaningful paradigm or for a meaningful patient triage, we need to develop a bleeding score, and that is why we have the precise DAPT score, which takes 5 parameters: the hemoglobin, the white blood cell, age, creatinine clearance, and history of prior bleeding, and assign them some points to each of them. The total score is 100, and if you have a score more than equal to 25, you have a high bleeding risk. So what is the relevance of precise DAPT score? So this is an interesting slide which has shown the effect of this precise DAPT score in patients with or without complex PCI. As I have already told, those with more than 25 precise DAPT score, they are at a high bleeding risk. Now, if your concern is bleeding, for both complex and non-complex PCI, you should go for short DAPT. But if you consider the ischemic risk or the MACE, if it is important to you, depending on the patient you are dealing with, then for non-high bleeding risk patient, you should go for long DAPT for both complex and non-complex PCI. Now, if we go for a short DAPT in patients with high bleeding risk, as suggested by the previous slide, what about the ischemic? Their answer to this problem has been given by the master DAPT trial that was published in NEJM in 2021. They have taken any one of the high bleeding risk criteria, that is precise DAPT score more than 25, or the patient having any systemic disease or malignancies with increased bleeding risk, or documented evidence of anemia or blood loss, age more than 75 years, or chronic therapy with steroid, NSAID, or stroke. So any of the, and of course, not to forget about oral anticoagulation. The patient must be on oral anticoagulation for 12 months, and any one of these entails the patient to be included on the study. And they were subjected, randomized to two regimes of antiplatelet therapy. One is abbreviated DAPT, where DAPT was given only for 1 month, followed by either a single P2Y12 inhibitor for 11 months, or if the patient was already taking oral anticoagulation, he is given aspirin or clopidogrel for 6 months along with oral anticoagulant for 11 months. And in standard DAPT, after 1 month, the patient is continued on aspirin and any one of the P2Y12 inhibitor for 11 months, or if he's taking oral anticoagulant, the aspirin clopidogrel combination is given for 3 months, followed by either aspirin or clopidogrel for 8 months, along with oral anticoagulation for full 11 months. What was the choice of P2Y12? Well, that depends on the investigator's discretion and as you can see from this slide, this abbreviated DAPT is non-inferior as far as the net adverse clinical events or major adverse clinical events are concerned, and it is definitely superior when we consider the major or clinically relevant bleeding. And most interesting is that when you see the secondary outcomes like death, stroke, myocardial infarction, and bleeding, the abbreviated DAPT is non-inferior to the standard DAPT. So how long we can continue with DAPT in patients with low bleeding risk? We have seen about the high bleeding risk, where we are happy with short abbreviated DAPT. Well, if you see both the ESC and the ACC, the latest guidelines, they have gone for a prolonged DAPT. If you have a stable ischemic heart disease, it can be continued till 30 months. And if you have ACS, it may be continued up to beyond 30 months, provided the patient has low bleeding risk. Now, here is an interesting trial. What happens in patient with low bleeding risk? This is oft-peace trial. It was presented in American College of Cardiology conference in 2021 and published at same time in November 2021 in JACC. So they have enrolled 505 patients who were on 6 months DAPT and were checked by capsular endoscopy to have no ulceration or bleeding. Now these patients are randomized to receive either aspirin or clopidogrel or a combination of aspirin and clopidogrel and for 6 months, and were again rechecked by capsular endoscopy. So what they have found, interestingly, if the patient is put on DAPT, even in the low bleeding risk category of patients, there is a high chance of GI mucosal injury and high chance of GI bleed even in DAPT therapy. So SAPT performs better than DAPT even in patients with low bleeding risk. And the result with SAPT is similar for aspirin and clopidogrel. And this has led to a very interesting editorial comment by Dr. Bittel and Lane that this result should compel cardiologists to start thinking like gastroenterologists. So give enough importance to bleeding. Now, that is good. We'll continue with single antiplatelet therapy. But what if your patient have a high ischemic risk? Would you like to continue with SAPT? Now, this is an interesting study from Korea, the Kami-Renich registry, which was published in October 2021, and they have enrolled more than 13,000 patients with stable MI. That is definitely a very high risk category. And all of them have a high ischemic risk, that is the complex features, and they have taken 4 criteria. Number 1, unprotected left main PCI. Second, a long lesion where the stent length is more than equal to 38 millimeter. Third, multivessel PCI. And 4, if the patient has multiple stents, that is more than equal to 3 stents per patient. And the MACC, both a combined cardiac and cardiovascular adverse events were adjudged. It is basically a composite of all-cause death, MI, and stroke. The stents that are used are all second-generation DACE. They have a thinner start. They are in biocompatible or biodegradable polymer, which means that they ensure better healing. Now, as you can see, after 12 months of DAPT, if these patients, they don't have any adverse event, they are randomized to receive either a SAPT with aspirin or clopidogrel, or a DAPT, that is an aspirin and clopidogrel combination for till from 12 to 36 months. And what is interesting is to see, of course, the bleeding risk will be less with SAPT, but what is most interesting to see that the combined cardiovascular and cerebrovascular events are much less in the SAPT group, that is 4.2% as compared to 8.5%. And this benefit of SAPT for combined events were consistent across the diverse subgroups and including each complex features. So it was done by regression analysis and propensity score matching. However, this is a trial done among the Korean patients, and it is probable that the East Asians may be genetically more disposed to have fewer absolute ischemic events as compared to Westerners, maybe as compared to South Asians, and it may not be wise just to impose this data for routine day-to-day practice. Now, this is the latest ESC 2020 guideline in non-STEMI, which is again is showing that it is very obvious that both SCC and ESC has incorporated SAPT, especially in patients with high or very high bleeding risk after PCI. Now, which monotherapy we'll choose? Shall we choose clopidogrel? Shall we choose ticagrelor? Shall we choose prasugrel? Now, ticagrelor and prasugrel, they are better than clopidogrel in that they have more rapid, more greater, more consistent inhibition of platelet aggregation. And this translates obviously into more clinical benefit. And ticagrelor is an active drug. And there is no effect on ticagrelor or prasugrel on CYP2C19 as evidenced by the principal TIMI44 and this first two trial. Now, what to choose between ticagrelor or prasugrel? The ISA REACT 5 showed that prasugrel is better than ticagrelor for reducing death, MI, stroke, or stent thrombosis, and there is no difference of bleed. But ISA REACT 5 is a debatable trial as regards the study design, as regards the finding they have, and as regards the drug compliance with the patient cohort. So maybe we have to take it with a pinch of salt. However, based on this trial, prasugrel has been recommended in some guidelines as an agent of choice for loading before PCI as part of early invasive strategy. And we have also cangrelor, not yet freely available in India, can be used for periprocedural agent, and it is better than clopidogrel and even better than crushed ticagrelor and prasugrel. And the more CKMB elevation you have, the effect is more enhanced. And there is no effect of co-administered opiates. What about the genetic or the platelet reactive testing? It has been trialed, it has been tested extensively, and it has no proven efficacy. And the newer generation stents, they give better result with monotherapy. And so we have this latest network meta-analysis on, I have only, this is my last slide, in fact, last but one. 24 trials and a huge number of patients, and they have divided them into 4 groups. One is short DAPT for less than 6 months, midterm for 6 months, then 12 months, and extended term DAPT for 12 months. The short term DAPT plus followed by a P2A12 inhibitor has been shown to be non-inferior for ischemic risk, but superior for major bleeding or net adverse clinical events. If you look at the ischemic endpoint, you should prefer ticagrelor, and if you look at bleeding endpoint, you should prefer clopidogrel. The short-term, midterm DAPT is similar with aspirin, followed by aspirin monotherapy, doesn't provide any benefit as far as bleeding risk is concerned over 12-month therapy. And all these, they have less major bleed, but they have higher ischemic risk as compared to extended term DAPT. However, there is no difference in cardiovascular or all-cause mortality across the groups. So, ladies and gentlemen, we conclude that SAPT with a new generation P2Y12 inhibitor is favored. To stress ischemic endpoint, you should consider ticagrelor, and if you have a bleeding endpoint, you consider clopidogrel. However, if your age is more than 70 years, as shown by the popular age trial, clopidogrel is preferred because it is non-inferior to ticagrelor as far as ischemic risk is concerned in this age group and is associated with lower bleeding. In second, extended term DAPT, of course, it is still not irrelevant, and you have to consider in patients with ACS, on those patients with ACS who are at a higher risk of recurrent ischemic mess. And third and most important point, therapy should be individualized, and you should utilize 5W1H theory of antiplatelet monotherapy. What, who, where, when, why, and how. Thank you.
Thank you, sir, for your nice presentation on this controversial topic. And due to paucity of time, better to ask the questions in the floor, not in this dais. And I hand over the mic to my chairperson.
Thank you all.
I will like to request the chairpersons to kindly felicitate the speaker. And I will like to request Dr. Baburam Hazra, ex-HOD, Department of General Medicine, IPGME Hospital, to come up and kindly felicitate the chairpersons. So we move on to our next session. The topic for next session is urine as a liquid biopsy. And the speaker is Dr. Urpita Roy Choudhury. To chair this session, I would like to invite Dr. S. Kole, in charge ITU and Department of Emergency Medicine at Bellevue Clinic, and Dr. Shorbani Sengupta, Additional Chief Health Director and HOD, Department of Medicine, Bir Singh Hospital, Kolkata. I would like to request the chairpersons to kindly introduce our speaker for the next session.
Hello. So we are going to a very important session, and urine, how it's a gold standard nowadays for getting some important reports, important diagnosis also. So the speaker is Dr. Urpita Roy Choudhury.
She is a professor, Department of Nephrology, IPGMR, Kolkata. She is also a joint director, Regional Organ and Tissue Transplantation. Editorial board member, Indian Journal of Nephrology. Executive Council member, ISOT. Published more than 55 papers in multiple journals, national and international. Reviewer of multiple journals. Scientific committee member of ISN India, ISN East Zone, member of ISN ASN. So with these few words now, I will invite Dr. Arpita Rai Choudhury. I will also make you remind that for the last few years in our state, this organ transplantation has got a newer dimension, obviously with the active participation of Dr. Arpita Rai Choudhury. Dr. Arpita Rai Choudhury, please.
Thank you, chairpersons, for your kind introduction. A very good evening to the a very, very informative, but it is invasive. There are some situations where we cannot do renal biopsy, though we feel like doing, like patients are having low platelets because bleeding is an important risk. Patients who are on double antiplatelets, which we often find when the patients, renal patients are also cardiac patients too. So there are many situations when the patient is very sick, as an AKI patient admitted in ICU, where we cannot perform a renal biopsy. But if we look at the urine, that may serve as a window to the compartments of the kidney, the glomerular compartment, the tubular compartment, tubulo-interstitial compartment, and a little to the vascular compartment too. So with that, a quick guide, a very, very rapidly, easily accessible fluid it is. How we do urine sediment analysis is we collect urine, and within 2 hours of collection, it is best to look at it. If not, within 4 hours maximum. And macroscopically, we look at the color, clarity, turbidity. There are lots of urine biochemistry, and now up till the many other advanced tests, but we will restrict today to the common urine microscopy, which we can do in our departmental lab or bedside. We can place 10 ml urine, which we have to spin. So we have to have a centrifuge machine in lab, 1500 RPM for 5 minutes, reject 9.5 ml, gently resuspend the pellet and put on a glass slide and cover slip. You are done. And look at the bright field or phase contrast microscope. If you have at least 10 pills, you need to examine. And if you think that you would look at it, the bright field microscopy is the common light microscopy that we do. Phase contrast is an addition, and polarized light microscopy completes it. And where we will do it, and a suspicion or follow-up of a non-infectious renal disease, either primary or secondary, as the PGT just before was discussing. The syndromic presentation was nephrotic syndrome, and then it should be subdivided to primary and secondary nephrotic syndrome. Secondary nephrotic syndrome when the systemic renal diseases are part of it, and then she will be able to make a confident differential diagnosis, which will include many. And syndromic diagnosis should come first. That way, urine microscopy may help her to reach in the syndromic diagnosis. So primary and secondary to systemic diseases, tension and toxemia of pregnancy are two other indications where we need to look at, because many hypertension can be result of glomerular diseases, which we can get glimpse of once we look at the urine and get proteinuria and RBC together. And to the adverse effect of drugs also, suspicion and follow-up of the non-infectious postrenal disease. I have kept non-infectious because infectious, we do all know that we will order a urine routine and culture, but other than that, how important urine routine is. 3 to 5 red blood cells are normal if it is in excess, and the dysmorphic erythrocytes, I will show how they differ from isomorphic. The WBCs are also important. WBCs, you can get an infection, but when there is a sterile leukocyturia that may reflect the inflammation in the glomerular or the interstitial compartment, the epithelial cells are important, they stay in urine, but when they come in excess, that can indicate the tubular damage, as happens in ATN and AKI. And casts, some hyaline casts are not unusual even in health, but if you get erythrocyte, granulocyte casts, if you get excess of renal tubular cell casts, waxy fatty casts, and bacteria and yeast containing casts, or the pigment casts, they are all abnormal and they would indicate the cause inappropriacy to the clinical situation. The bacteria may be found in the urine, but always not. They are very important, but some appropriate geographical location with the bacteria in it may be useful. The lipids and crystals are also useful, particularly, you know, the cystine crystal is useful because it points out the diagnosis. That is the best diagnosis for cystinosis in constellation with the ideal clinical situation. The urate nephropathy, acute urate nephropathy with an abundance of uric acid crystals can help you to clinch the diagnosis. And oxalate, which may appear also in health, in some situations, they are the pathogenic things. So it's actually a clinician's test. You cannot interpret a urine routine report without history, physical examination, directed serum test, dipstick urine analysis, and imaging. You cannot use it completely. Particularly the history is very, very relevant to use it as a liquid biopsy. So why I have highlighted the manual urine microscopy, because of the huge number of the samples that you need to do, you may sometimes go to the automated urine analysis, which takes very little time, very efficient. And which advantage will be always there when you look at this. The pathologist for diagnosis, but while the patient is alive, the urine is our property and we should give proper attention to it. Age-old manual. So this is the urine wheel with the multi-sensory profile. In urine, it's various flavors. People didn't hesitate even to test it because the sweet taste and diabetes mellitus is after testing the urine, and that is there in history. Honey sweet and insipidus is the flavorless. And even to the extent the people were used to do their prophecy with the urine sample, health prophecy used to be done with the urine sample, that there was a poem by Gabriel that if the urine is wine colored, it will send you to health and all. I'm not going in detail because time will be a limitation, but it's real fun if you go into the history also. Bright field is typically the default microscope at which you should look at. This is the typical muddy brown granular cast which we see in ATN, acute tubular necrosis. This is the rouleau-forming RBCs when we find RBCs in excess. And this is the mixed cellular cast with a calcium oxalate stone. You can see the cast here. Cast is nothing but a scaffold of the TAM horseful protein on which excess of RBCs, excess of WBCs can be residing. Even the renal tubular epithelial cells, when they're secreted in excess because they are damaged and the tubule is shedding its epithelial cells, then the TAM horsefall protein scaffold may be used for deposition of those cells and they can form a cast. So RBC or WBC cast, when it is formed, usually they come from the upstream. Whenever there is RBC in the urine, the natural question is where from the RBC is coming. Is it the glomerular compartment or lower down the urethra? One thing will require a cystoscopy and the other thing will require a biopsy. So how to point out that which is the primary investigation that we will jump to? The urine microscopy is a big help. The phase contrast microscopy is of big help in identifying the dysmorphic RBCs. These are the bleb-like features that you can see. One isomorphic RBC is usually round and doesn't have this bleb-like picture, which comes up very prominently in a phase contrast microscopy. The bright field microscopy actually relies on the differences in transparency. Phase contrast transforms the path of light traveling through an object to enhance its contours. So the contour is enhanced and we are interested in the bleb-like contour of this RBC. So if you look at these are the true acanthocytes which we are interested with, the bleb-like ones. And this is a crenated RBC, which you can see in the liver disease or many other situations, which is not the right acanthocyte. This is a crenated RBC. The normal RBC is, this is a ghost cell. And these two are the ghost cells. The normal RBCs, you can consider these a non-nucleated cell. And this is the typical acanthocyte. And this is a destroyed dysmorphic RBC. So again, if we use a polarized light microscopy, it is a polarized filter to view the sediment components of birefringence, as if you are looking at the slide with a polarized sunglass. Instead of helping to reduce the amount of light reflecting in your eyes on a sunny day, these sunglasses will allow you to pick out the objects that are normally hard to see, like crystals and lipids. Here you see a lipid cast, a typical Maltese grease appearance that you read due to presence of cholesterol esters. And these are the three pictures. This is the bright field microscopy. This is the phase contrast microscopy. And here you will see the polarized microscopy. So do we need to stain urine? Yes, you can stain. It will enhance the recovery of the things and can little more highlight. The commonest classic stain is the Sternheimer-Malbin stain, which is a supravital stain, meaning it is applied to the live sediment and fresh out of the centrifuge. Steps for using this stain are simple. Split the urine sediment during sample production, allow the SM stain to one slide and assess under bright field examination. What does it add? It improves resolution. It can tell about the age of the cells. And this is the RBC SM stain in bright field. And the outdated one is the staining for eosinophils. Initially, it was right stain. Then Hansel came up as a more efficient stain to stain the eosinophil. And the utility of eosinophiluria in acute interstitial nephritis then has come into question, because not all types of acute interstitial nephritis are excreting eosinophils in urine or does have abundance of eosinophil in the biopsy also. So there is a lack of specificity in this context. So urine examination is relatively inefficient to pick up acute interstitial nephritis. Why we are interested about acute interstitial nephritis? Because we are finding it more and more in hospital acquired AKI. We are using more and more antivirals and advanced antibiotics, and those are causing acute interstitial nephritis, which is important to pick up, because acute interstitial nephritis is not a benign disease. Over time, we have learned steroids can protect the kidneys from the deleterious effect of AIN. If it is allowed to stay and prolong, it will cause CIN. The Sudan stain is looking at the fat globules in urine. And this is the innate pigmented cast. This is the bilirubin cast. And this you can see the hemoglobinuria, where after centrifugation, you can see the
plasma is red colored. So it is not myoglobin, the hemoglobin itself. So acute interstitial nephritis, the clinical picture is very necessary. Some intake of drug or some indigenous substances, which can give you a similar picture of sterile pyuria, eosinophiliuria, leukocyte casts, and urinary biomarkers. You can see an inflammatory infiltrate with eosinophilic predominance. Times they are not so even. Prognosis and treatment, I have told you. So in picking up that, over time, it has been found that urine routine examination is not that efficient. Initially, we thought that the specificity is good, but now we are finding that the specificity is not good enough. So nephritic syndrome that the girl was discussing, there was that not actually a nephritic syndrome, the PGT that was being discussed. So it was active urine sediment, proteinuria, hypertension, and decreased EGFR. Proliferative glomerular disease, small vessel vasculitis, and anti-GBM disease are usual causes. So nephritic syndrome is characterized by large number of erythrocytes and RBC casts in urine, which RBC casts particularly a telltale feature of glomerular involvement, and sometimes we need to put them on therapy without waiting for a biopsy if they are very sick. And acanthocyturia, more than 5% urinary RBCs, as I have shown, acanthocyturia is usually specific for glomerular disorder. I will go fast, within 2-3 minutes, I'll finish it up. It is important that persistent of hematuria is increased risk of relapse of ANCA vasculitis and higher risk of progression of ESKD to IgA. So we need to look at you can see the look at serial urine samples also. You can see in the distal tubule how the cast is generating and the RBCs are being deposited. You can see the parameters here that the dysmorphic RBCs more than 25% have quite high positive predictive value and quite good specificity to identify the glomerular disorder. Similar if hematuria and proteinuria is together present. If the proteinuria is in the glomerular disease proteinuria more than 3.5 gram, then again it is very useful. And of course, the proteinuria and hematuria together are the most important pointers. You can see the renal tubular epithelial cells in bright field and fast contrast microscopy. When ATN is the diagnosis and we are fumbling that whether we should give fluid or not fluid, sometimes an excess of RTCs in urine may tell you that if you are going to see a bad ATN and you may give a fluid challenge. And these are the finely granular cast and coarse granular cast that we see in ATN, and more than 6 epithelial cell casts and granular casts, they can predict equally as the Atkins score is predicting the course of acute kidney injury. So other thing is the crystals, that some crystals we will find in health also, some calcium oxalate crystals, but mostly we do not find crystals in here. And acyclovir is common in use where you can find a crystalluria and proportionate renal injury, and amoxicillin, ciprofloxacin also, and the sulfadiazine is used in waste in excess. And Dr.
for
cystinosis, I have told
Please
that that's-
summarize it.
Yeah, this is the last slide. So this is the crystals that you are seeing, the polychromatic uric acid crystals, which you can find out in acute uric acid nephropathy. And these are the calcium oxalate monohydrate and bihydrate, the coffin lid crystals that you are seeing there. So with that, I know many questions will be there, but there will be no time because I knew that the time will be too limited. So you may
Thank you so
me
much.
in my hospital, in my academics.
Okay, thank you so much, Dr. Raichaudhuri, for your, as usual, excellent presentation and very lucid on the topic. But I think you had many things to say as the topic was urine as liquid biopsy. So liquid biopsy and stressing on this non-invasive procedure, urine and, as a liquid biopsy. But just.
Management of cancer.
Severe
basically,
but apart from these conditions, I think liquid biopsy, urinary liquid biopsy, which are also meant for pre-diagnosis of other some non-urological malignancies or cancers. That's the most important non-invasive part. Okay. Yeah. That's cancer cells. Yeah. Okay, thank you. Thank you. If you have anything to add.
No, thank you very much. Thank you very much, madam.
I will like to request the chairpersons to kindly felicitate Speaker Ma'am. I will like to request Dr. Krishna Roy Basu to come up and kindly felicitate the chairpersons. Now we will resume our session on case-based discussion. To chair the session, I will like to request Dr. H.S. Pathak, Dr. Shivendu Ghosh, and Dr. Bhaskar Ghosh to come up on the dais.
Welcome back to our previous case-based discussion session. On behalf of the organization, I beg apology for a bit change in schedule and keeping the other presenters to wait. So we invite Dr. Devruk Sengupta to present his case.
Oh, thank you, and sorry again on my and other chairman's behalf that sorry for the delay, for the interruption. Please bear with us. Both the floor and the participants are requested with us. Thank you very much.
Good afternoon, respected chairperson, sirs, and my respected teachers and my dear colleagues. I would like to present an interesting case of a patient with chronic ulcer and polyarthritis. So my patient was a 48-year-old man, farmer by occupation, who came to us from South Chobbish Pargona district in the month of July 2021, when we were all busy with dealing with the second wave of COVID. He had chief complaints of pain in multiple joints of the body since last 8 months, ulcer over both elbows since last 7 months, and swelling around both eyes since last 5 months. He was apparently well 8 months ago. Then he experienced an insidious onset joint pain. First, it affected the small joints of both hand and feet, namely the wrist joint, the metacarpophalangeal, the proximal interphalangeal, and the metatarsophalangeal joints of feet. Later, it progressed to involve the large joints of both upper and lower limbs, like elbow, knee, and ankle joints. Pain was also associated with swelling and tenderness. There was early morning stiffness. And due to the severity of the pain, there was limitation of physical activity also. The pain was mainly in the appendicular skeleton, and there was no history of any low back pain. He also complained of ulcers since over the both elbows since last 7 months and over the knuckles since last 3 months. They were painful, associated with burning sensation, but no discharge was present from the ulcer, and there was no preceding trauma. With the due permission of the patient, I have shown the picture with the of the patient. We can see the swelling around the eyelids, which patient complained since last 5 months, but it was not associated with any visual disturbance, or any red eye, or any pain in the eye. And there was not associated with any pedal edema or any generalized swelling of the body. On further inquiry, he also gave history of Raynaud's phenomenon on exposure to cold water since last 1 year, and history of alopecia since last 3 months. Coming to the negative histories, there was no history of any fever, rash, photosensitivity, no history of cough, dyspnea, orthopnea, any decreased urine output, high colored urine or frothy urine, any dryness of mouth or eyes, any dysphagia, no history of any weakness or any skin tightening, no history suggestive of dactylitis, no history of oral or genital ulcers or any high-risk sexual behavior. There was nothing significant in the past history, and patient was non-diabetic, normotensive man, and with no history of any addiction. No similar illness in the family, and regarding treatment history, he received some NSAIDs for his painful the arthritic joint pains, as well as the painful ulcers. He also received some topical ointments and oral antimicrobials like cephalosporins and aminopenicillins. So we are dealing with a 48-year-old gentleman with history of bilaterally symmetrical small joint plus large joint polyarthritis, periorbital puffiness, Raynaud's phenomenon, and non-healing ulcers. Coming to the general survey, patient only had mild pallor. Rest of the general survey was within normal limits. All vitals were normal. All peripheral pulses were present and equally palpable. No lymph node were present. The ulcer was closely examined. You can see that it is a punched out ulcer with regular margin, clean base, and undermined edges. And the ulcers did not have any active discharge. The ulcers were present in both elbows, on the knuckles of both hands, as well as one ulcer was present on the left foot also. Multiple pitting ulcers are seen in the fingers of all the 4 limbs. Here you can see the pitting ulcers, as well as there are pitting scars also in some of the fingers. Coming to systemic examination, the musculoskeletal system examination reveals swelling and tenderness of small joints of hand and feet, restricted range of motion of the elbow joint, and the pain throughout the range of motion. No history, no finding of any sacroiliac joint tenderness or any midline tenderness was seen. No muscle wasting was also found. Nervous system examination was essentially within normal limits. Tone, power, reflexes, everything was normal. On examination of respiratory system, we found fine inspiratory crepitations over both the bilateral lower part of the posterior chest wall. Gastrointestinal and cardiovascular system was again within normal limits. So coming to the investigations. A routine hemogram, complete hemogram showed only a mild normocytic normochromic anemia, and liver function test revealed a borderline low serum albumin with mildly elevated around 2 times the upper limit of normal, mildly elevated the transaminases. Inflammatory markers were tested. ESR was 66 in first hour. CRP was around 2 times the upper limit of normal, and LDH was on the higher side. Urine routine analysis was within normal limits with no albumin. Serology for HIV and hepatitis B and C were all non-reactive. A creatine phosphokinase was done. It was just on the higher side of normal. It was just 173 with 170 being the cutoff. Rheumatoid factor anti-CCP were negative. ANA was negative, and ANCA was also negative. USG whole abdomen showed mild hepatomegaly only. And chest X-ray, you can see that on both sides there was mild lower lobe patchy opacities. So keeping in mind the respiratory system examination findings, we went ahead and did a HRCT for the patient. And here you can see there are bilateral fine fibroreticular opacities in both sides of the chest, The report also came like that. Apart from fibroreticular opacities, there were certain small ground glassing opacities, as well as multiple subpleural consolidations. We discussed it with the radiologists also. They also confirmed that it is what we are thinking. It was early interstitial lung disease changes. So apart from the 4 facets that I already described earlier, we were now added with ended up having a 5th facet, that is the interstitial lung disease. So if we try to consider all the facets, we started considering the differentials. We thought, can it be a simple case of rheumatoid arthritis? Because almost everything can be explained with rheumatoid arthritis, like rheumatoid arthritis related ILD, non-healing ulcer due to rheumatoid vasculitis. Raynaud's phenomenon, although not so common, but it can be still seen in up to 15% patients of rheumatoid arthritis. But the only odd point was periorbital puffiness. Lupus was ruled out because we already had a negative ANA report. Then we thought the possibility of anti-synthetase syndrome, which can explain a polyarthritis, ILD, Raynaud's phenomenon, a non-healing ulcer also sometimes, but there was no fever, no myositis, no muscle weakness was present, and mechanics hand that we commonly encounter in anti-synthetase syndrome, that was also absent in the patient. We also considered possibility of the systemic sclerosis with the 10% of systemic sclerosis patients can present without any skin tightening. So it was, although it was lowered down in the differential, but we still considered it. Sjogren syndrome can present with polyarthritis, ILD, and Raynaud's, but a patient with Sjogren syndrome without any dryness of mouth and dryness of eye, that was less likely. Now, one thing that could explain all the facets was dermatomyositis, because periorbital puffiness can be due to the equivalent of heliotrope rash. The ILD is very common in dermatomyositis, polyarthritis, Raynaud's, all can be seen. But a non-healing ulcer, it is not so common. And another odd point was that the patient was clinically totally lacking any evidence of any muscle inflammation. So even if it had to be a dermatomyositis, it had to be a clinically amyopathic dermatomyositis. In order to confirm this whether the patient is either truly amyopathic or he's having clinical amyopathy, but at subclinical level having any muscle inflammation, we went ahead and did a electromyography study for the patient, but it came out to be normal as well. Myositis profile was also done. In our lab, the myositis profile not only shows the myositic specific antibodies, but also antibodies like the anti-synthetase antibodies like Jo1, PL7, PL12, these antibodies were also done. So the anti-synthetase was also out of the differential. Then we went back to the all the facets. So we considered that a clinically amyopathic dermatomyositis patient with a non-healing ulcer. So could it be a patient of MDA5 dermatomyositis? That is the melanoma differentiation associated protein 5 dermatomyositis. And in this myositis profile, MDA5 was not included. So we contacted the laboratory and told them that we specifically want to see the MDA5 assay in this patient. So they did that for us, and it came out to be positive, strongly positive, which confirmed our clinical diagnosis of an MDA5 dermatomyositis. Patient was started on prednisolone at 1 milligram per kg per day, and also started on injection cyclophosphamide according to NIH protocol as per consultation with the Department of Rheumatology for his early ILD changes. This is the picture of the patient after 2 weeks of treatment. You can see the periorbital puffiness has almost disappeared. The ulcers are also healing. Right now, the patient is under a joint follow-up of our department and Department of Rheumatology. He is doing pretty well. Here are my references. Thank you for your patience.
This time we'll invite a few questions and from the audience also. We have a number of rheumatologists in this hall. Professor Dr. Senupta is there. On my behalf.
Thank you, sir. My only question or suggestion was, have you gone for ANA profile? ANA may be negative, but it may be either a overlap syndrome or a mixed connective tissue disorder. So you have to exclude the U1 RNP. as well, because there are features of systemic sclerosis overlap.
Yes, ma'am, we did an ANA profile, only
The
row
profile you have
50
not shown.
I have not shown.
Yes.
Only row 52 was positive and it
Row
is.
52 was positive.
But that is a non-specific antibody, so we did not consider it.
Okay, thank you.
Yeah, anyone, Madhuchanda, can you proxy in my presence, in my absence? Can you do any question? Do you have any questions? Madhuchanda, Sarojit, because we are requesting for Dr. Partha Sarkar, anyone to volunteer about any questions to this presentation? Dr. Tapos, do you have any question regarding this presentation? No. So I have got, yes, Sarojit, no. No, I am just echoing the, I mean, Dr. Sengupta's, you must do, or if you have done it, please speak out about E1 RMP. These are telltale evidence, renowned. So you should do that. That's. Okay.
Was there any evidence of ILD clinically?
Yes, sir, the fine inspiratory crepitation, that was the only finding that we got. Patient did not have any shortness of breath, any cough or any other symptom.
So you did not keep it in your clinical diagnosis, ILD. I mean, while you are planning the following symptoms and signs were present, you did not put ILD. Why? That's what I'm asking.
Sir, that was I showed the 4 facets after the history. After examination, I did not show anything. I showed one after history and one after examination as well as investigation. I have showed it twice. So after history, there was nothing suggestive of ILD.
But after examination?
Yes, after examination, definitely.
Thank you. So I am requesting the next presenter, Dr. Ritik Ghosh, to present his case. Dr. Ritik Ghosh, please.
Shall I start? Good evening, everyone. Good evening, my respected sirs. So I'll be talking about a case of short stature. 14-year-old female, she presented to us with her grandmother in the OPD. Her chief complaint was she is not attaining her expected height with respect to her peer group. Now, she's been observing that for the last 2 to 3 years. Her grandmother says she's very lazy, lethargic. She's not playful at all for the last few years. She hasn't attained menarche yet. Apart from that, there were no other significant family history. Her parents were of average height. She is not on any medications. And there is no history of any developmental delay in the past. On clinical examination, the patient was alert, conscious, cooperative. She had a very puffy face. Neck gland was not visible, not palpable. There was no other significant findings on general survey. Skin was dry. Coming to the vitals, BP, pulse, respiration, everything was quite stable. Sometimes she used to suffer from bradycardia. On examination, respiratory system examination was within normal limits. So was the cardiovascular system and the abdominal examination. In nervous system examination, there was no evidence of any mental retardation. There was no focal neurological deficits. However, the ankle jerk was delayed. Coming to the genitalia examination and the secondary sexual characters, the Tanner staging was B1, A0, P1. That is, there was no secondary sexual characters yet. At 14 years of age, the genitalia was unambiguous female and estrogenized in nature. Now we are thinking of the various causes of short stature. Before we can classify or approach the case, we have to understand if this is a proportionate or disproportionate short stature, and then keeping the various other causes in mind. For example, familial short stature or constitutional delay, or any kind of endocrine abnormalities, we have to do these anthropometric measurements. Now, from this slide, it is clear that chronological age is more than the height age, which is again more than the bone age. I've given a picture of the X-ray of her left wrist and hand to describe the bone age. The total height was 116 centimeter. The upper segment, lower segment ratio was 0.9. Now, we all know the upper segment and lower segment ratio reaches 0.9 at the adult age, like near about 18 years. So this is, I would call it disproportionate. BMI was 18.6, which was on the lower side. Coming to the investigations, routine tests were all normal because we needed to rule out any kind of chronic disease. She was not suffering from any chronic diseases. As to her knowledge, she was not a hypothyroid, but on our investigations, we found out that FT4 was low, TSH was high, and anti-TPO was quite high. So basically, it was an autoimmune thyroidism that she was suffering from. We also sent for the other hormonal assays like cortisol and a paired serum ACTH. Now, this revealed like there was adrenal insufficiency. Prolactin was okay, and FSH and LH were okay. There was no discrepancy there. On the radiological investigations, USG whole abdomen, it was normal. Ovaries were bulky with multiple follicles within it. Coming to the neck, thyroid gland was, there was no focal lesion in the thyroid gland, and there was heterogeneous parenchyma with increased vascularity. Then we did an MRI of the HPA axis. The MRI showed that the pituitary gland was enlarged. It was measured 10.2 into 14 into 12. There was no focal lesion, but it was enlarged overall and a convex superior surface. So we diagnosed this case to be a case of short stature and hypogonadism because she was suffering from primary amenorrhea, probably due to a long-standing untreated juvenile autoimmune hypothyroidism. The mechanism behind this, which we predicted, was due to the autoimmune hypothyroid. There was macroadenoma, like there was a specifically the thyrotrope releasing cells in the pituitary were enlarged, which in turn suppressed the other cell lines of the pituitary, leading to a hypogonadism. And short stature was basically due to hypothyroidism. So the patient was first started on hydrocortisone because the HPA axis was already suppressed. If we substitute thyroxine first, then BMR will increase and it will precipitate an adrenal crisis, insufficiency. So hydrocortisone was started, and after 3 days, we started her on levothyroxine, and the dose was gradually increased, doubled after 2 weeks. Thank you.
How common is this episode? Have you searched the literature? How common is this?
This presentation, how common? Do you have any literature support?
No, I don't have a literature support.
Any interaction from the audience?
Would like to know the exact cause of hypogonadism.
The exact cause of hypogonadism probably is due to the suppression of the gonadotrope cells. So that is causing a decreased FSH and LH release from the pituitary itself. Due to the feedback macroadenoma, probably of the thyrotrope cells, it's suppressing all other cell lines, including all the other hormones. And that is also the cause for the cortisolemia also.
So all of that you're explaining with that single cause.
Dr. Sonja Banerjee, will you respond, though it is not your specialty?
14 years.
Can hypogonadism be an essential feature of childhood hypothyroidism?
Can you just...
In childhood hypothyroidism, do we get hypogonadism or not?
No, hypothyroidism itself can be a cause of hypogonadism.
Yes.
Yes.
particularly in childhood hypothyroidism, because the
Actually,
percentages-
she has been suffering from this for the last 2 to 3 years. Now we have no document because she is 14 years old. Now the normal definition of primary amenorrhea, we keep the age cutoff at 16. But in this particular case, since she already has a short height that is less than 3rd percentile, in such cases we have to evaluate for primary amenorrhea even before.
The important differentiating feature between adult onset to childhood onset hypothyroidism is presence of hypogonadism feature childhood hypothyroidism. You have put forward as an explanation that enlargement of selective thyroid that has suppressed the gonadotropes in the pituitary. I think this is a too far-fetched idea. This seems good as an explanation, but whether this really happens?
You want to say something?
Yes, sir. Can we think this case as a pan-hypopituitarism? What is the pan-hypopituitarism? What is the difference? The presentation of pan-hypopituitarism and childhood hypothyroidism. Because you have shown low cortisol, your high TSH and all these things.
Yes, hypopituitarism, there won't be high TSH.
Any other DD?
Clinically, we can differentiate between a creatine dwarf and a pituitary dwarf. Mental retardation is a sort of creatine. And there will be hypercholelemia, low bradycardia, other features of hypothyroidism, which are not there in presence of pituitary dwarf.
How can you explain the adrenal insufficiency here? Primary adrenal insufficiency, I think, because cortisol was reduced with raised ACTH. How can you explain that? You didn't, in your diagnosis, that was not included. Can the whole the thing be due to some autoimmune phenomenon with multiple?
That's, we had been looking for if there was any kind of additions, but we didn't get anything in favor of that. We thought about an autoimmune process, but
No. You told that serum cortisol was reduced with a very high ACTH.
Not very high.
ACTH was around 5, and serum
Yeah,
cortisol
high,
was reduced
yes.
and ACTH was high.
Yes.
So that means that the patient was also having adrenal insufficiency.
Yes, she had adrenal insufficiency.
That was not included in your diagnosis, and multiple endocrine glands are involved, and can't it be in some autoimmune feature which has involved many glands?
Yes, autoimmune does involve many glands.
Can it be a part of polyglandular autoimmune syndrome?
That's what I was asking.
Yes, we have been looking for that, but we just found NTTP positive, no other autoimmune markers.
What have you think about that? I'm just repeating that. Patient has got low cortisol, high ACTH. You are telling that it is due to the pituitary problem, cortisol has decreased.
Actually,
ACTH has decreased. So the pituitary problem, due to secondary DH, population of more and the whole thing has increased. ACTH has increased. Can it be?
Actually, primary adrenal insufficiency, there are 4 stages of that. The level of ACTH does not match with that, so we cannot call it entirely primary adrenal insufficiency also. It's not fitting the criteria of stage 1, it's fitting stage 1 primary adrenal insufficiency, but not stage 2, 3 or 4.
Okay, thank you.
I think it is too much for.
So we are inviting the last case by Dr. Souvik Sarkar.
First of all, I'd like to wish a very good afternoon, a very good evening to the respected chairpersons, respected faculty members, and all my dear colleagues assembled here. The case that I'm going to be presenting today is titled New Wine in an Old Bottle. My name is Dr. Souvik Sarkar. I'm a second-year postgraduate in the Department of General Medicine, Medical College and Hospital, Kolkata. A fair disclaimer before I begin. Despite what the title says, my patient is not an alcoholic. Okay. Yes. This man, who is a 65-year-old male patient, a Muslim from religion and farmer by occupation from Bhota, was admitted in our indoor department on the 28th of March 2022. He came with complaints of shortness of breath and cough for the last 2 years, and the cough had increased in bouts and was associated with black for 2 months, and he was associated with fever for 1 week. History of presentness. The dyspnea was gradual in onset. It had been persisting for 2 years, and the patient had reported that he had observed some relief on taking puffs from inhalers. And the cough, which was associated with the onset of dyspnea, actually worsened 2 months. Blackish expectoration. The patient also complained of fever, which was intermittent low-grade and the maximum recorded temperature was 100°F. The patient is also a chronic smoker for the last 30 years. He had a consumption history of around 15 pack years. And he had a past history of pulmonary TB, which was diagnosed 10 years back, for which he took anti-tubercular therapy for 6 months. And the duration of treatment was uneventful. And he was compliant to his medication. Negative history, there is no history of any orthopnea, PND, pedal edema, hemoptysis, significant weight loss, blood transfusions, or multiple unprotected sexual intercourse, jaundice, or bowel or bladder disturbances. In the general survey, the relevant points were that there was grade 2 painless clubbing noted in bilateral upper limbs. The neck examination was positive for trail sign on the right side. The blood pressure was 130/80. The patient was tachypneic at rest and had an SpO2 of 89% under room air. And the temperature recorded at that time was 100°F. On respiratory examination and in the inspection part, what we noticed was the patient had pursed slip breathing. The patient had a positive trail sign on the right side, as is being shown in the image here. The chest appeared barrel-shaped and shoulder drooping noted on the right side. Also, there was dressing done on the right side of the chest in the suprascapular area. On palpation, what we observed was that the trachea was shifted to the right. There was restricted movement on breathing in the apical and infraclavicular area as compared to the left. Vocal fremitus was increased in the right infraclavicular area. On percussion, we found that there was impaired percussion note over the right apical and right infraclavicular area in the right MCL. And in auscultation, we observed that in the right infraclavicular, in the right axillary region, there were cavernous breath sounds with coarse crepitations which changed in character on coughing, and vocal resonance was found to be increased with bronchophony. There was no whispering pectrology. The other areas of the lung were found to have vesicular breath sounds with prolonged expiratory phase and bronchi. The other system examinations were within normal limits. Now, a provisional bedside diagnosis for this patient was made as a case of right-sided apical lung cavity with lung fibrosis, likely post-tubercular with superimposed infection in a known case of COP, not complicated by respiratory failure or cor pulmonale at the time of examination. What seemed pretty run-of-the-mill now will eventually change its course once the investigations unfold. So let's take a look at the investigations. So on the complete blood count, there was a hemoglobin of 9.8 with a slightly microcytic hypochromic picture. The ES was raised. The CRP at the baseline was raised at around 75.9. The serum globulin was also high. The serology showed that the patient was IgG negative and the coagulation panel was normal. A chest X-ray was performed, and this chest X-ray shows hyperexpanded lung fields, flattened diaphragms, and we can clearly see a cavity in the right side of the lung with what appears to be a light. Sputum study performed. The sputum studies of AFB day 1 and day 2 turned out to be negative, and Ramsden and CS that was sent was positive for Protea rabilis, which was sensitive to piperacillin, and moderate amount of pus cells were also seen. CCT thorax was performed for the patient. As we can see from the images shown in the slides here, we can see that there is hyperextended lung fields, presence of fibrosis in both areas of the lung, and some traction bronchiectasis as well. And the most important feature is we can see a clear-cut fungal ball, in this case in a irregular lung cavity present in the right-sided apex. The following image also mirrors what I've just said right now. There is presence of a fungal ball. These are the axial views, and these are the other plates. So the CCT thorax report came to be right apical lung cavity with querymycetoma, lung fibrosis was treated, impactions were found, and traction bronchiectasis was found. The next logical step appeared to be a final aspiration from the cavity itself. And that is where the whole matter turned on its head.
The CT-guided FNSA report showed fibrillary necrotic D with branch fungal hyphae branching at acute angle, which was suggestive of aspergilloma. At this point of time, the patient has already been started on itraconazole. And the patient was also showing some movement because he had been given a prior course of IV antibiotics, that is IV Bipso. But the aspirated material had also been sent to the microbiology department for fungal culture and sensitivity. And lactophenol cotton blue mount showed a morphology that was resembling Pseudal Escherichia coli or Scedosporium complex infection, which was morphologically distinct from Aspergillus. So the HP report was certified, but the came to be something entirely different. So this is the LPCB mount, the picture that we can see over here. What separates this particular organism from Aspergillus species is that the hyphae, if you note over here, the Aspergillus and this species both have sept and hyaline. Both of the hyphae show acute angle branch. So of the Scedosporium complex infections, we can see that the branching is rather haphazard. Also, we can see the typical tennis racket shaped cladospores present in the slide. And these features, because of the conidiogenesis, this we can differentiate Aspergillus from the Pseudal Echalacia and Scedosporium complex infection. So, the patient underwent treatment with injection piperacillin and tazobactam for 10 days. Tablet itraconazole was started. Dyspnea improved with nebulization and patient were discharged before the microbiology report had come in with MDI therapy. CTVS to be the future course of the patient because he had a high risk of perioperative mortality. On telic follow-up, patient appeared to be doing better. Now, the organism that we had isolated, let us have a short discussion on it. The Pseudal Escherichia, which is Pseudal Escherichia Scedosporium complex. Now, what exactly is it? Pseudal Escherichia is basically the sexual form of the common fungus. The asexual form is the Scedosporium. They have emerged as an important cause of life-threatening infections in humans. In fact, this is an emerging pathogen, especially in immunocompromised hosts. The most common site of their infections is actually respiratory tract, that is the lungs. Also, certain other sites have also been found, like the bone, soft tissues, and the sinuses. So the recent molecular studies have indicated that this complex actually includes several species. In the lungs, they can cause several infections that actually mimics the pulmonary profile of Aspergillus infections. There can be an allergic bronchopulmonary pseudal asteriasis. There can be non-invasive infections like pulmonary mycetoma and fungal ball. There can be invasive infections, among which the commonest is pneumonia, bronchopneumonia, and also mimics a pneumonia that is often seen in patients who have suffered from near drowning. So pneumonia has been found to be the commonest manifestation. The clinical radiological profiles are similar to that of Aspergillus species. Distinction can only be made on culturing. Treatment includes surgical. So these are some of the case reports that I've published from 1955 up to 2000 and around 200 published work detailing infections caused by this organism. Recently, in 2008, Pseudal Escherichia boydii infection isolated from the sinuses, isolated from patients suffering from pansinusitis have been reported from South India. And why this kind of cases are very important to note is because unlike Aspergillus, these species are actually highly sensitive to miconazole. The miconazole has been to have excellent best in vivo activity against organisms. With this, I would like to conclude my case.
First, you explain to the audience what is trail sign.
Yes, sir. Trail sign is the presence of abnormal protuberance or prominence of sternocleidomastoid on that side of the neck to which the trachea has shifted. The reason for this being that the pretracheal fascia covering the sternocleidomastoid becomes more relaxed when the trachea is to that side, which is to have an abnormal prominence of sternocleidomastoid muscle.
What may be the predictive factors for development of fungal infections in this patient?
Sir, there are mainly kinds of fungal infections that we observe. One is the allergic bronchopulmonary pseudoceriasis. Next is the invasive and non-invasive. For the infections, the most common host factor is immunocompromised host. Immunocompromised hosts like those who are suffering from diabetes, those who are receiving cancer chemotherapy, those who are suffering from HIV/AIDS. These are the common people who are predisposed to invasive infections. Those who are predisposed to non-invasive infections are actually those who have suffered from tuberculosis and have developed a lung cavity, or it can also be seen in sarcoidosis and in those who have suffered from COPD.
Patient was non-diabetic.
Yes.
And was there a history of steroid intake?
No, sir. This patient, there was no history of oral steroid intake, but the patient had been using inhaler infrequently for the last 2 years. And he not specify which inhalers he had used. We has asked him to bring inhalers from home, which he could not.
What was the cause of this black sputum?
So the cause of the black sputum, whenever we consider the entity of black sputum in clinical medicine, we have to keep certain things in. First of all is we have to keep whether there is any fungal infection, whether there is any occupational lung disease such as coal workers pneumoconiosis, or if there is any underlying necrotic process undergoing in the lungs. Likely, sir, this patient has a cavity and the fungal infection was not only was initially non-invasive, but now it was actually involving the lung tissue. Because of the involvement of lung tissue, subsequent necrosis, now he was coughing up black sputum.
So your sputum examination showed Aspergillus.
Yes, it showed actually a bacterial organism which was sensitive to piperacillin tazobactam, for which he received therapy. But the FNAC results, however, proved to be otherwise.
One very important question.
Yes, sir.
What is the recent treatment of aspergilloma? Most recent treatment, and we are avoiding nowadays CTVS involvement by the good physicians or intensivist. What is the most recent treatment of aspergilloma?
Sir,
Cavity
I'm
with-
not aware.
Okay,
I'm not
thank
aware.
you.
Thank you, sir.
So,
Sir.
oh,
I will like to request all the postgraduate trainees to come up on the dais. The postgraduate trainees who have presented their cases to come up on the dais and collect their mementos from the chairpersons.
hey, here is the one.
Dr. Shelly Jain. Dr. Devrup Sengupta. Dr. Ritik Ghosh. And Dr. Shovik Shorkar. I would like to request Dr. Shoykot Dotto and Dr. Sorojit Bonik to come up on the dais and kindly felicitate the chairpersons.
The persons who have already, PGTs who have presented their cases, just one information, the result will be published, declared tomorrow in the valedictory session. Out of 4 candidates, 2 will be given prizes. So please do attend the valedictory session tomorrow evening.
Good afternoon, everyone. So we are now at the last part of today's event. So may I request Professor Gautam Rai Chaudhuri, Professor Colonel Dr. Gautam Dhar Chaudhuri, sir, to please come up on the dais as a chairperson of this final event. Also, we have co-chairs, Dr. Uttam Bishwas. Please come in the dais. May I request Dr. Piyush Kanti Mondol. Dr. Piyush Kanti Mondol, please come up in the chair as a chairperson. So we need one on more chairs here. And also, may I request Dr. Omyo Dwari to please come up as a chair, and may I request our chairpersons to carry forward this session.
So we are in the last sessions, and without much ado, may I invite the first speaker, Acho, the second speaker who is now going to speak first, Dr. Sanjay Bandopadhyay. He is going to speak on spontaneous bacterial peritonitis, suspect, treat, and prevent. Dr. Sanjay.
Good evening, respected chairperson, my senior teachers, learned members in the audience, and dear guests. It's always a privilege and pleasure for me to be here in API, because though I am a junior faculty compared to most of the seniors present here, I still enjoy to hold the record of being the youngest secretary of API West Bengal. And it's always a good homecoming for me whenever I am at API dais or speaking to the API audience. My topic today is spontaneous bacterial peritonitis, and this topic has been selected by my longtime friend, Professor P.S. Kormokar. How to suspect, how to treat, and how to prevent. Because this is a variety of peritonitis, which is unlike the infectious peritonitis, usually falls in the domain of people who deal with liver diseases. This is a peritonitis that complicates liver disease. And we all know in a liver disease and gut, it's always the chicken and egg story. Liver disease, immune dysfunction, gut dysbiosis, bacterial translocation, more insult to the liver, more dysbiosis, more and more and more. So it's always the so-called chicken egg story. The risk of bacterial infection in cirrhosis is increased in manifold. It's increased in patients with cirrhosis and ascites. And distinctly this bacterial infection of ascitic fluid, unlike tubercular peritonitis or other bacterial peritonitis, this bacterial infection of ascitic fluid is called spontaneous bacterial peritonitis, because classically this was considered to occur spontaneously without any intervention. These patients will not have any intra-abdominal surgically treatable source of infection. One of the earliest case series incorporated a record of 9 different patients. Most of them grew coliforms in their ascitic fluid with varied presentation and a significant morbidity. This was reported from the UK, and subsequently interest was generated in this entity. Over the last 3 decades, in spite of significant advancement in management of liver disease by and large, and also the utility of antibiotics, the prevalence of acute kidney injury, hepatorenal syndrome, and death, and their prevalence in patients with spontaneous bacterial peritonitis has not changed much. This is because of increasing intervention, more and more resistant organisms, and more elderly people with liver disease and hospitalized patient of liver disease developing as and more. Present mortality, even with early diagnosis of treatment. So 1 out of 5 of all patients of spontaneous bacterial peritonitis, in spite of treatment, will die because they have an underlying significant liver disease that gets decompensated or may present in acute or chronic form. The prevalence is 10% of all outpatients, and I believe majority are asymptomatic. There are 5 different ways in which the spontaneous bacterial peritonitis can present. A minor percentage presents with local signs and symptoms or the systemic signs and symptoms of fever. Major percent, however, present with worsening liver function or other well-recognized complications of liver disease like hepatic encephalopathy, shock, renal failure, or GI bleeding. 50% of outpatients are asymptomatic. So any patients of stable chronic liver disease, when there is some suspicion of deterioration or appearance of newer complications, consideration should be given regarding the presence of bacterial peritonitis. Infection, these was an inflammatory reaction that results in an increase in neutrophil in the active fluid. Warning that a diagnostic paracentesis for any or whatsoever may be the reason they are admitted in the hospital. A diagnosis should be carried out. It rule out spontaneous peritonitis. This is applicable more in patients who are presented with any new complication or deterioration of pre-existing. We owe much of the knowledge that therapy of spontaneous peritonitis to this gentleman in California, Bruce Allen Reunion. He popularized and established the notion that ascitic fluid polymorphonuclear count of more than 250 is sufficient to spontaneous without recourse to the need of ascitic fluid culture. Simple microscopy is good as and strips are used. Though blood culture should be sent to the antibiotic therapy, ascitic fluid culture positivity is not a prerequisite to diagnose SBP. There are many variants of SBP. The classic variant is a combination of both positive ascitic fluid culture. But in common clinical practice, ascitic culture is commonly. Often even get cases who have a raised polymorphonuclear and negative culture. This be of spontaneous bacterial peritonitis. The classic SBP and this CNNA are treated in the same way because their outcome is same. There is a group of trans-colonizing bacteria which will give positive polynuclear count. No increase in PMN. This group are called loyal bacteriocytes, but they are non-neutrocyte. Significant rise in that usually occurs in surgical. Monomicrobial neutrocytic bacteritis is a condition when there are growth of bacteria and they are such not treated. But if this patient on respiration still show growth of bacteria, they should be treated, or if they develop symptoms of infection, they should be treated. Secondary bacterial peritonitis is suspect multiple or culture when there is inadequate response to therapy. Most of the patients usually need CT scan to rule out intra-abdominal infection, and of them may need radiologic or surgical drips. Similar to spontaneous bacterial peritonitis, the infection of hepatic hypertrophy is not called spontaneous bacterial, called spontaneous empyema. This is the nomenclature National Ascites Club since 1996. And the diagnosis of spontaneous bacterial empyema, that is infection of hepatic advanced is pleural fluid culture and neutrophil of than 250. Even a negative 500 in absence. Is easy as difficulties because the landscape of bacterial resistance is continuously changing and it's challenging the recommendations for antibiotic. And there are now widespread presence of resistance bacteria in the healthcare environment in the last decades are worried about multi-drug resistant, expendable drug resistance, and pan-resistance bacteria. And in this August gathering, most of the people know the nomenclature for what constitutes multi-resistant, expandable drug resistance, and what is pan-drug resistance since this landmark in 2012. Two groups of patients come with SBP. One are community-acquired SBP, and one are symptoms of SBP. And our approach for this patient should be different. Ample antibiotics should be started in all patients of SBP, though there is some controversy whether the patients who are stable tolerate orally without GI bleed, they respond as well to antibiotics. But usual is to start intravenous. We have a long list from which to choose: third generation cephalosporin, piperacillin tactum, carbapinem, and vancomycin. Because most of the studies have shown these very well against bacteria commonly called are guard derived and recognize the ascitic fluid. However, the choice of the environment of infection, it depends on the bacterial resistance profile in the locality, and it also depends on the severity infection. For community-acquired SBP, the first choice is third generation cephalosporin. If there is chance of resistance or history of previous treatment or multiple admission or previous intervention, then piperacillin tazobactam or now comes with nosocomial SBP. Piperacillin tazobactam is the first choice. Carbapinem, when ESBL producing extended spectrum beta lactamase producing Enterobacteriaceae considered, and carbapinem with daptomycin, which is a glycopolypeptide, or linezolid when MDR bacteria is considered.